Morning. I'm going to make sure you're awake. Let's try that again, everybody. Good morning. Hey, does it feel like you're at a house of worship yet? Giving you a taste of things. It is a pleasure to be with you all today and a privilege to be part of this conversation that brings together so many leaders, scholars, clinicians, researchers. I learned that a third of us are chaplains here at the meeting, which is, woohoo, way to go chaplains. But also we are gathered with so many people who have acronyms that can spell out the entire alphabet. And it's an honor to be with you, to see so many of these. I sometimes think people talk about government being alphabet soup, but some of these credentials are giving us a run for our money. My personal credentials are MNPS, and I'm just gonna let that rattle around in your brain and say, what is that? We'll talk about it later. But we're here at the intersection of spirituality and mental health, two domains that for such a long time were treated as completely separate categories. One got fluorescent lighting, couches, and insurance billing codes, while the other got casseroles, pulpits, and prayer chains. I say pick your poison. I was thinking this morning, riding on the T, and I was like, wait, there's some interesting things that are shared here for at least academic mental health, which I know many represent. With our faith communities, we have the shared love or the shared hatred of committee meetings. Look at how many things we can come together around. But certainly we are all representing this intersection, this growing understanding of the interdependence of spirituality, mental health, and faith. This comes at a time when we know in the federal government, we know from the research that individuals seek out clergy, they seek out faith communities when they are in crisis. So when someone's life is falling apart, they say, who can I call? I'm gonna call the person who prays for me. I'm gonna call the person who cares for me and ask how they can help. And it matters. That's a fact that should matter to us in the system, it should matter to us systemically, and we should think about ways we can engage that. So it raises a central question. How should we understand the role of faith communities within the broader mental health ecosystem? And what are the implications for research, practice, and policy? As we mentioned, my name is Ben Odell, and I've had the pleasure of serving in the Center for Faith in the U.S. Department of Health and Services for more than 20 years. I'm here on behalf of Dr. Monty Burks, who deeply wishes he could have been here, but got pulled into other responsibilities at the department. If he were here, I would guarantee that it would be more inspirational because his story of lived experience in the criminal justice system, as well as a history and lived experience with substance misuse, moving through roles in state government that engage faith communities as meaningful and measurable partners in addressing behavioral health challenges, and now leading at the highest levels of government is just that. His story is inspirational. But I hope to bring some form of inspiration from the work that we've done over the past decade with a national point of view about the activity of faith in mental health. I was thinking this morning about Dr. Schultz. It's given me lots of experience. He talked about anti-psychiatry. I'm coming to you, I was trying to make a list. I deal with anti-faith, anti-government, anti-politics, anti-mental health, and I'm sure I'm missing a few. These are all the different conversations and challenges that we all face as we think about the different antis in the world and honestly how to bring them together, because part of the work of the HHS Faith Center focuses on integrating trusted community-based capacity, including faith communities, into federal health and human service strategies. Said another way, my job is to bring all those antis together in an awkward conversation where hopefully they leave trusting each other just a little bit more. So as we think about faith and mental health and how they intersect, my attempt at an inspirational and also aspirational argument is this. Modern mental health often struggles to adequately engage the relational and existential dimensions of human suffering, and faith communities, while imperfect, represent one of the most important institutional contexts through which meaning, belonging, and social support are mediated. Said less academically, sometimes people don't only need treatment. Sometimes they need someone who notices when they disappear for a few days. Sometimes they need someone who speaks to a higher authority on their behalf because they have no words left to say. Sometimes they need a hope and a prayer. and someone to walk through the valley of the shadow of death with them. So let's start off by acknowledging the dominant framework in medicine and mental health that has been the biopsychosocial model. It recognizes that mental health is shaped by biological processes, psychological dynamics, and the social context. It's an important advance over purely biomedical approaches. Because sometimes medicine in our more modern era has occasionally approached human beings as malfunctioning machines. But a growing body of scholarship suggests this framework may be incomplete. It's not in its components, but in how those components are operationalized in practice. In many settings, systems still function in ways that implicitly reflect a more mechanized understanding of the person. Symptoms are identified, dysfunction is categorized, interventions are applied. This approach has led to important clinical gains, but it may also narrow our understanding of what is it to be human. Because persons are not simply biological systems to be stabilized. They're relational, meaning-seeking, identity-forming. They're individuals whose lives unfold with relationships, commitments, losses, and belonging. In conversations across governments and health systems, I've often seen how often our medical infrastructure is built around checklists. A checklist can tell us whether someone has received a diagnosis or a prescription. They save lives, they create accountability, and to be clear, checklists matter. But checklists have limits. A checklist is a pretty poor reflection of how a person is rebuilding their life. Because recovery is not only a compliance process, recovery is more like a story. It has memory, rupture, identity, relationships, setback, meaning, and hope. Dr. Ross Marin last night reminded us that suffering reminds us that we're human. Said another way, we don't read stories unless they include just a little bit of suffering. We don't read and tell and retell stories devoid of conflict. Conflict, tension, drama, they're what makes stories stories. And one of the challenges in mental health is that our systems are often better designed to check off a diagnostic code than to accompany the longer narrative how a person puts their life back together. This is where I find the work of Ian McGilchrist helpful conceptually, not only as a strict neurological claim, but as a way of describing the two modes of attention that our brain may embody. One part of our brain attends to parts, procedures, and control. The other attends to context, relationships, meaning. Health systems, let's be honest, insurance companies attend to the first. They're really good at parts. They focus on procedures and producing an air as if everything is under control. But for me, and I hope for you, recovery is so much about the second. Recovery occurs in the context of relationships that are rebuilt and built anew, meaning that is renewed from the ashes of suffering and instability. A person is not only a set of variables to be managed, a person is a life being lived. And this is not merely theoretical. Secretary Robert F. Kennedy described the current moment this way: we are not just in a health crisis, we're in a spiritual crisis. Regardless of anyone's politics, the broader observation reflects something many disciplines are noticing: increasing loneliness, fragmentation, and an erosion of meaning. Again, Dr. Ross Marin so beautifully pointed these out to us last night. And to add to those thoughts, you might say that Americans right now are experiencing something like an existential buffering failure. They're connected to everything and attached to almost nothing. The question then is whether our systems of care can adequately be equipped to engage these emerging dimensions of our present challenges. So what we do know, and we've established and talked about multiple times, is that there are more than 10,000 quantitative studies examining religion and health, which means at this point, academics have studied church attendance about as far as we can take without attaching Fitbits to every single Presbyterian. Across diverse methodologies, including longitudinal cohort studies and meta-analyses, several consistent findings emerge, and I think it's important for us to state those. Religious participation is associated with lower rates of depression, reduced substance use, lower suicide risk, increased life satisfaction, and increased sense of meaning. These meta-analytic estimates suggest that roughly there's a 30% reduction in depression, meaningful decreases in substance use, and strong associations with reduced suicidality. As we've mentioned multiple times, Tyler Vanderweel and colleagues have argued that when associations persist across multiple populations, multiple designs, and rigorous controls, they begin to carry inferential weight. Leads us to an important interpretive conclusion. Religious participation can function as a social determinant of health. Now, it's important to state this carefully. This does not mean religion is a magic force field. Recent interdisciplinary synthesis from the Wheatley Institute similarly finds that the weight of the evidence points to the beneficial associations, while also establishing necessary and important element of complexity and nuance. Religion likely operates through multiple operating mechanisms, social connections, behavioral structures, identity formation, ritual participation, and serving as a moral community. In other words, what appears in the literature as religious participation may reflect a constellation of relational and existential processes that are themselves protective. When researchers say people who gather weekly with a community that knows their name, checks on them, gives them purpose, feeds them occasionally, and tells them that their life matters, they do better mentally, maybe we shouldn't be so completely shocked. If these associations are robust, the next question is, through what mechanism might religion influence mental health? Several pathways are well documented: social support, behavior norms, meaning making and coping, identity formation, ritual and embodied practice at the same time. It's important to recognize that religion is not uniformly positive. Religious experience, like so much of our experience, is heterogeneous. It can function as resilience, social support, moral grounding, and existential meaning, but it can also involve spiritual struggle, exclusion, shame, interpersonal harm. Scholars such as Kenneth Pargament, such a leader in this field, has emphasized the distinction between positive and negative religious coping for all of us to better understand. This nuance matters. Because the goal here is not to romanticize religion. If you grew up in a house of worship, you know that some communities can simultaneously feed the hungry, visit the sick, save marriages, and somehow start a civil war over carpet color. Human institutions are complicated, and religious institutions are not exempt, nor are our mental health professions and institutions. We're complex creatures in a complex structure that sometimes should get unsurprisingly complex. So let's talk about those complexities. Clinical systems are designed appropriately around diagnosis, intervention, symptom reduction. But many individuals are also navigating isolation, disconnection, a loss of identity, a loss of community. We see these clearly in the transition from inpatient care back to community life. Individuals often leave care with a diagnosis, a prescription, and a plan. But they often leave without a durable system of relational support. During that critical 30 to 90-day period following discharge, appointments may not happen quickly enough. Contact may deteriorate. Engagement may weaken incrementally rather than dramatically. The result is a well-documented pattern in the literature: high readmission rates, repeated cycling through systems of care. In checklist terms, many things may have been done correctly. The discharge plan exists, the referral was made, the medication was prescribed, the boxes were checked. But in story terms, the person may be standing at the edge of a disrupted life, asking, who am I? Where do I belong? Who will sit with me at dinner as I break into tears in the rush that comes from healing? Clinical systems frequently organize around episodes. Human beings organize their lives around stories. There's meaningful and measurable difference between a system that records a symptom that is abated and a community that can accompany recovery. This is not a solely clinical problem. It's also relational and operational. It's about whether a system can exist that can initiate contact quickly, sustain engagement over time, and remain present where people actually live. And this can be where faith communities can be so particularly important, because a faith community already functions as a site of sustained relational presence, an environment of repeated interaction, and networks of accountability and care. In other words, for centuries, they provided and will continue to provide an engagement infrastructure, not because we asked them to, but because of who they are and what they do. I was just reminded of this visiting a program outside of Philadelphia, where I had the opportunity to sit with several individuals in recovery and hear their stories, along with other individuals from the administration. One man shared how a severe season of depression had led to job loss, housing instability, and enormous strain on his marriage. But through treatment, support, and time, he and his wife had begun to rebuild stability around their lives. As a part of that process, that mental health system providing treatment asked him a simple question: is faith important to you? When he said yes, they were able to connect him with a local congregation that had been trained and encouraged on how to walk alongside individuals recovering from mental illness. He then shared how he'd recently lost his wife to illness. He spoke very honestly about how easy it would have been to spiral back into that same dark place of depression. But he said something I've not forgotten. He said it was not that he wasn't suffering, he was suffering deeply. But his faith and the community that surrounded him and reinforced that faith kept him from suffering alone. They kept checking on him. They kept showing up. He kept his head up, his eyes forward, and helped him keep moving through the hardship of pain rather than being consumed by it. And in the middle of grief, they helped him find meaning without denying his faith. And as he told his story, his pastor was sitting right there next to him, encouraging, supporting, affirming many of the things he was saying, but also giving him space to share his story. Clinical care stabilized his life. The community helped him sustain it. So let's take and think about some of these mechanisms and ask how we might be able to think about systems that might inform these strategies. We know that the mental health system faces well-documented access challenges, workforce shortages, geographic disparities, financial barriers, persistent stigma. At the same time, there exists a parallel infrastructure. More than 370,000 congregations embedded in communities across the country. This leads to an important systems-level observation. Faith communities are not external to the mental health system. They're already a part of it, though often informally and unevenly integrated. There are pastors across the country currently functioning as unpaid frontline mental health workers armed primarily with prayer, compassion, and probably absolutely no sleep. Here, communications research helps us provide an important insight. The Frameworks Institute has demonstrated that public understanding of health tends to default towards individual-level explanations, personal behavior, individual resilience, isolated pathology, rather than structural or relational explanations, community conditions, institutional trust, social isolation, systems of support. And this matters because how we frame mental health shapes the solutions that we might be able to imagine. If mental health is solely framed as an individual clinical issue, the solution space narrows. But when we can expand that frame to include relationships, community infrastructure, meaning-making institutions, a broader range of interventions become possible. Which means the question is not, can a faith community replace clinical care? Absolutely not. But I would strongly advise against a youth pastor attempting differential diagnosis after Wednesday night pizza hangout. The opportunity before us is complementary. Clinical systems and community systems do different things, but increasingly we need both. To operationalize this, the center is often thinking about the work existing across the continuum. It starts with awareness. It starts with houses of worship, learning more and becoming stigma-free communities where we can talk about mental health openly. It then builds into opportunities for peer support, AA programs, substance use treatment meetings, community health workers, individuals who are willing to walk alongside individuals in treatment. It can ultimately lead to, and we continue to see, many houses of worship offering licensed clinical services within their house of worship. They can partner with providers, they can co-locate services, they can provide referrals into the clinical care system. This framework allows us to move beyond whether or not faith communities should engage mental health and instead asks at what level, under what conditions, and what safeguards under which should that integration occur. Because church involvement in mental health can mean anything from here's a support group and a referral list. It can look like a treatment site in a house of worship, in an office as a part of that facility. But sometimes, unfortunately, can also mean Brother Steve watched 2 YouTube videos and believes he's now a trauma specialist. Let's be clear, those are not the same things. The relationship between faith communities and mental health is best understood as complementary. Faith communities often provide trust, proximity, social capital, meaning-making. Mental health professionals provide clinical expertise, diagnostic capacity, evidence-based care. Together, these domains can expand access, improve responsiveness, and support whole person care. And I think whole person care matters because human beings are not just a collection of symptoms. People are stories. People are relationships. They're meaning-making creatures trying to answer questions like, do I matter? And those questions don't disappear just because someone has a billing code. The medical system is designed to ask, was the intervention completed? Faith communities are formed to ask, how is this person's story unfolding? And for mental health, both questions matter more than we often realize. Clinical systems are organized around episodes, but human beings live their lives through a narrative. And if that's true, then the challenge before us is not merely clinical. It's organizational, it's relational, and ultimately structural. The question becomes, how do we build systems of care that are capable not only of treatment, but sustained human connection? That is what we're working on at the HHS Faith Center. At the Faith Center, our role is to help move from informal interaction to structured collaboration. We work to identify community-based capacity, support collaboration, and integrate these into broader public health strategies. This reflects a broader shift toward community-based care, prevention and early intervention, and recognition of the social determinants of health that it can include religion. Faith communities in this context represent a scalable form of relational infrastructure within that mental health system. And in a sentence that is so deeply federal, I think a PowerPoint slide just received its wings somewhere. Underneath that bureaucratic language is a very human reality. People recover better when they are connected. And through our work with federal agencies building their capacity to work with faith groups, and through our work to build the capacity of faith communities to engage those federal and mental health and health systems, we're writing a story where there's space for our respective strengths to be part of the solution set for mental health. So let me conclude by pulling a few of these threads together. The evidence suggests that spirituality and religious participation are meaningful and associated with important mental health outcomes. The systems analysis suggests that faith communities are already functioning as part of the system. And the policy challenge before us is not whether these communities matter, it's whether we're willing to engage them thoughtfully, responsibly, collaboratively, as part of a broader system of care. Because if we take seriously the goal of supporting whole persons, we must also take seriously the relationships and the communities that shape meaning, belonging, identity, and ultimately hope. And perhaps one of the central questions of this moment is not simply asking, how do we treat mental illness? But also, how do we rebuild communities of presence, trust, and belonging in a society that is frequently and increasingly defined by fragmentation? Treating mental illness is not only about symptom reduction. It's also about whether people feel connected to meaning, to purpose, to one another, and to hope. That's why I believe in the ancient idea of shalom still matters. Not pure peace merely as the absence of conflict, but peace as the presence of wholeness, the restoration of relationships, the rebuilding of belonging, the recognition of human dignity, the kind of community where people are not abandoned in their suffering, but seen, carried, and deeply known. Government cannot create that kind of society alone. Clinicians cannot build it alone, and clergy cannot pray it into existence alone. But together, perhaps we can create communities where people are not defined only by their diagnosis or dysfunction, but are supported as human beings whose lives still carry meaning and possibility, where suffering is not faced alone, where recovery is not reduced to a checklist, and where people are reminded that they still belong. And maybe that part of what true healing looks like is not merely surviving in isolation, but being restored to relationship, to one another, to community, to purpose, and for many, to God. That's a kind of society worth building, and I believe it's worthy of all. Thank you.